Hey guys, welcome to Med 10. So in this video, we are going to learn about the pharmacology part of the phenytoin. So phenytoin is an important anti-epileptic drug which is most commonly asked in terms of UG examinations. So make sure you watch the video till the end. So we'll discuss about the phenytoin. So phenytoin, as I said, it is most commonly used anti-epileptic drug, and the another thing is that you have to know more about its mechanism of action. So the entire mechanism of action of anti-epileptic drugs I have discussed in separate video. Make sure to watch that so that you will get a better understanding of the phenytoin. So phenytoin binds to the voltage dependent sodium channels, thus prolonging the inactivated state and prevents the further entry of sodium ions into the neuron. So it binds to the voltage dependent sodium channels, it prolongs the inactivated state and prevents the further entry of the sodium ions into the neuron, thus stabilizing the neuronal membrane. It reduces the intraneural sodium concentration, causing membrane stabilizing effect. Then after that, thus it inhibits the generation of repetitive action potentials. By reducing the intraneural sodium concentration, it inhibits the generation of repetitive action potentials, thus finally preventing the spread of seizure discharges. So again I am repeating it again. Listen to it very carefully. Phenytoin binds to the voltage-dependent sodium channels. It prolongs the inactivated state and prevents further entry of sodium ions into the neuron. It reduces the intraneural sodium concentration, causing membrane stabilizing effect, thus inhibiting the generation of repetitive action potentials, thus preventing the spread of seizure discharges. So this is about the mechanism of action of phenytoin. Moving on to the pharmacokinetics of the phenytoin. Phenytoin is widely distributed and bound to plasma proteins. It is metabolized in the liver and also it has dose dependent elimination in the body. That is, it follows the first order kinetics with a t-half of 10 to 24 hours. Pharmacokinetics, it is widely distributed and bound to plasma membrane, the plasma proteins. It is metabolized in the liver and it has dose dependent elimination. That is the first order kinetics with a t-half of 10 to 24 hours. Then what are all the uses of phenytoin? Phenytoin is used in terms of generalized tonic-clonic seizures, that is GTCS. We use phenytoin. It is also helpful in terms of partial seizures. It is helpful in the trigeminal and other neuralgias. Then it is also helpful in the status epilepticus. So we'll have a separate video on the status epilepticus. What is it? What are its management? We'll have a separate video. We'll watch that. Then these are all the uses of the phenytoin. That is the generalized tonic-clonic seizures, partial seizures, trigeminal and other neuralgias, and status epilepticus. Then what important thing is the adverse effects of phenytoin. So these are again very important. Again they can be asked in terms of a separate heading in the UG examinations, as in what are the adverse effects of phenytoin, and they can also ask in a viva as well. So adverse effects of phenytoin, it exhibits dose dependent toxicity. So what do we have? We have the hypertrophy and hyperplasia of the gums. We have hypersensitivity reactions, hyperglycemia, hypocalcemia, and finally fetal hydantoin syndrome. So what do we have? We have hypertrophy and hyperplasia of the gums. We have hypersensitivity reactions, hyperglycemia, hypocalcemia, and finally the important side effect is the fetal hydantoin syndrome. So this is when the pregnant woman uses phenytoin to control her seizures, it can cause fetal hydantoin syndrome. So what is this? We have cleft lip, cleft palate, and digital hypoplasia in the fetus. So when the pregnant woman uses phenytoin for controlling her seizures, the fetus can have cleft lip, cleft palate, as well as digital hypoplasia. So this is called as the fetal hydantoin syndrome. Now, when the concentration of the phenytoin increases, it causes furthermore toxicity. We have CNS side effects, that is the vertigo, ataxia, tremor, as well as the headache. Then we also have the severe side effects, which are the hypotension and cardiac arrhythmias. Then we have the GAT side effects, which include the nausea, vomiting, gas, and dyspepsia. So when the concentration of phenytoin in the body increases, it causes furthermore toxicity. In terms of CNS, we have vertigo, ataxia, tremor, and headache. In terms of CVS, we have hypotension and cardiac arrhythmias. In terms of GAT, we have nausea, vomiting, and dyspepsia. Then we have the another important question, that is the what is fosphenytoin. So fosphenytoin is a prodrug of the phenytoin. So fosphenytoin, it can be given either IM or IV, and it is converted into phenytoin in the body by the phosphatases. Another important thing is that it can be administered either in the normal saline or the glucose, and comparatively it has less irritation on the waist compared to phenytoin, and it is preferred over phenytoin in terms of status epilepticus. So they might ask what is phospheniton and what are its advantages over phenytoin. You have to remember, phospheniton is a prodrug of the phenytoin. It can be given either IM or IV. It is converted to phenytoin by the phosphatases. It can be administered in normal saline and glucose. It has less irritation on the veins compared to phenytoin, and it is preferred over phenytoin in status epilepticus. Thus, ending the lecture with thought for the day. Listen to it very carefully. You have to value time over money and possessions. So, thought for the day is value your time more than money or possessions. So, thank you so much for watching. Make sure to subscribe and hit the like button. And if you found this lecture helpful, make sure to share it to your other friends and people who want to learn more about the pharmacology part. Thank you, and I'll see you in the next video. Bye.